We are going to be discussing amyotrophic lateral sclerosis, or ALS. What is ALS? It's a progressive neurodegenerative disease that's unfortunately 100% fatal. Let's break down the word. A meaning no, myo meaning muscle, and trophic meaning nourishment. So literally, it means no muscle nourishment. Lateral refers to the area of the spine where the brain tells the muscles what to do. Sclerosis means hardening, which refers to the lateral areas hardening, stopping the signals being transmitted to the muscles. It is characterized by scarring and degeneration of motor neurons in the lateral portion of the central nervous system, or CNS. There are two different types of ALS, sporadic and familial. Sporadic can affect anyone and is the most common type of ALS, accounting for 90 to 95% of all cases. Familial is genetic and accounts for 5 to 10% of all cases. Risk factors for ALS include heredity, which if a person with ALS has a child, their child will have a 50-50 chance of having the disease. Age. The most common age diagnosed with the disease is between 40 and 60 years old. Sex. Before the age of 65, there is a slightly more high incidence in men than women. Smoking. Smokers are 2 times more likely to develop ALS than non-smokers. Lead exposure is also a risk factor, and a recent study showed that those who served in the military are at a higher risk of being diagnosed with ALS.
Okay, so ALS is a neurodegenerative disease. So because of this, you'll see this markedly diminished voluntary control of muscles, and it's going to be secondary to damaged motor neurons, pretty much. So also at play here is the malfunction of glutamate. So like most neurotransmitters, glutamate's really going to only be present at the neuromuscular junction of nerve cells for, really brief periods of time. But in cases of ALS, glutamate's really not cleared efficiently at all, and this is going to eventually lead to a toxic environment for most motor neurons. So based on these two tidbits, it's clear that ALS is going to have a notable presence in the central nervous system, more specifically in really all areas of the brainstem and the spinal cord. So the cognitive dysfunction seen with ALS is going to stem from both upper motor neuron lesions and lower motor neuron lesions. So for example, the devitalized voluntary control that we talked about may be the manifestation of like a lower motor neuron lesion of the anterior horn, and this is where, the efferent message is being sent from the spinal cord to the muscle. But, the specific areas and systems that are affected are also potentially dependent on the phenotypical nature or expression of the ALS. So with bulbar ALS, the corticobulbar tract is going to be damaged, and this is going to result in, slow and distorted speech, stuff like that. And with extrapyramidal ALS, the extrapyramidal system is going to be the victim. And this is going to lead to weakened postural control and weakened locomotion. And also, ALS has been purported lately to have a stake in the autonomic nervous system. But, this is one of those things where Judy would throw like 3 or 4 question marks up there because we're not really completely sure of it quite yet. But as the disease progresses, we see a more expansive effect. So it's eventually going to involve the limbic system. And here's really where we begin to understand why, there's this moodiness and emotional erraticism that sometimes is present in later stages. And the dysfunction is really with emotional processing, and it's caused by the damage to both prefrontal cortex and the amygdala. And these are 2 areas of the brain that we really know, or we're sure that are going to affect emotion. And the endpoint for most people with ALS is the failure of the respiratory system and the respiratory muscles that allow for people to breathe. So really from this, it's clear that ALS has really multi-systemic effects.
Cognitive impairments are seen in half of the people with ALS. Some impairments include lack of attention, abstract reasoning, planning, language comprehension, working memory, and problem solving. Bodily impairments include wasting and atrophy of muscles, which leads to weakness and limited mobility. The extensor muscles become weaker than flexor muscles, especially in the hands of those with ALS. Drooping of the head and pain can result from extensor muscles in the cervical region becoming more weak, leading to possible lumbar lordosis. People with ALS may have problems swallowing, chewing, and articulating, and many complain of drooling because automatic swallowing is not present. Respiratory muscle weakness can lead to respiratory distress in those with ALS. When the upper motor neurons are affected, the people with ALS typically have weakness in the facial muscles. They usually have loss of inhibition and lack of spasticity and dexterity. And these patients typically have problems swallowing, chewing, and articulating. When lower motor neurons are affected, the first evidence is generally insidious onset of asymmetrical weakness. There is also fasciculations of the tongue present, dysarthria leading to a hoarse or nasal voice quality and the inability to sing or shout, and muscle cramps.
For every 100,000 people, 2 cases of ALS are diagnosed, which equates to around 6,400 diagnoses every year. The U.S. estimates will show around 20 to 30,000 people are living with ALS at any given time. So who is affected? When we look at who is affected, we can break it down into gender, race, or occupation. Men are often affected more than women, about 1.5 times, with the majority of cases involving patients between 40 and 70 years old. We find whites are twice as likely to develop ALS than African Americans and Hispanics, and anyone serving in the military is also twice as likely to develop ALS. So, what is the overall prognosis for these individuals? Sadly, prognosis is poor for those with ALS, with an average survival time of only around 3 years. This is due to the complications of the disease that affect the systems of the body, ultimately impacting the respiratory abilities of an individual, leading to death. As the disease progresses, home health and palliative care are probably the best options for the later stages of ALS, so consideration of a living will is important. Lastly, the National ALS Registry is a congressionally mandated program for U.S. citizens to help collect information on who gets ALS and potential causes as a way to help find a cure. While the prognosis is still bleak, this registry will provide the potential for a better future for others with the disease.
In the initial stage of ALS, diagnosis can be challenging due to signs and symptoms mimicking other diseases such as myasthenia gravis, spondylotic myelopathy, multiple sclerosis, spinal muscular atrophy, and multifocal motor neuropathy, just to name a few. It is important to be certain of the diagnosis so that the proper treatment can be initiated. Certain diagnosis methods have proven to be effective in differentiating ALS from other similar diseases. Electrodiagnostic tests can help differentiate ALS from diseases such as myopathy and neuromuscular transmission disorders. The criteria for diagnosing ALS requires that the needle EMG examination show evidence of active and chronic denervation in at least 2 of 4 regions: brainstem, cervical, thoracic, and lumbosacral regions. Neuroimaging of the brain and spinal cord can be useful for differentiating ALS from other disorders such as brainstem stroke or multiple sclerosis. When applying an MRI or CT scan, we need to be specific to the clinical presentation of the signs and symptoms. As with the previous 2 methods, clinical laboratory tests are meant to rule out other diseases. Some of the commonly performed lab tests include complete blood count, a blood chemistry, or creatine phosphokinase test. Lab results will generally report back with normal results for ALS. Genetic testing can be performed to identify genetic defects in some familial types of ALS. Recent research has shown that in some populations there is a mutation present in a high proportion of patients with no family history of ALS. A muscle or nerve biopsy is the rarest form of diagnostic testing, but might be considered if the presentation of ALS is atypical. The results could confirm the presence of denervation and reinnervation, or possibly could lead to an alternative diagnosis. The presence of small angular fibers is consistent with denervation, and fiber type grouping is consistent with reinnervation.
So let's talk about the management of ALS. The medical management of ALS includes doctors prescribing medications for the patient to help reduce symptoms such as sleep disturbances, fatigue, pain, constipation, and excessive saliva. Doctors may also prescribe medications to help reduce nerve damage, control muscle spasms, and help with muscle stiffness. Several medications may be required for positive results. However, this combination has multiple drug interactions and an increased incidence of drug side effects. As well, drug resistance can develop with prolonged periods of medication. In terms of physical therapy in the management of ALS, physical therapists may incorporate some low-impact exercises such as walking, aquatic exercise, and stationary bicycle riding to strengthen muscle, improve health, and help with depression. PTs may also add in range of motion and stretching exercises to help with muscle spasms and to help maintain the patient's range of motion. Various assistive devices may also be incorporated to help maintain as much mobility as possible.